Welcome back everyone. Last week we established what epidemiology is and why it matters for healthcare managers. This week, we're getting into the quantitative heart of epidemiology, how we measure disease frequency in populations. These measures, incidence, prevalence, mortality rates, are the vocabulary of epidemiology. When you read a report saying that diabetes prevalence is 10% or that the incidence of hip fractures is 5 per 1,000 person years, you need to understand exactly what those numbers mean and how they were calculated. More importantly, you need to know which measure is appropriate for which question. If you're planning hospital capacity, you care about prevalence. If you're evaluating a prevention program, you care about incidence. Using the wrong measure leads to wrong conclusions. Before we get to specific measures, let's be precise about basic terms. Epidemiologists are particular about terminology, and for good reason. A ratio is simply one quantity divided by another. The numerator and denominator don't have to be related. The male-to-female ratio of 1.05 means there are 1.05 males for every female. The numerator isn't part of the denominator. A proportion is a specific type of ratio where the numerator is included in the denominator. The proportion of Canadians who smoke is smokers divided by all Canadians. It ranges from 0 to 1, though we often express it as a percentage. A rate technically involves time in the denominator. Incidence rate is cases per person time. Velocity is distance per time. When we say rate in epidemiology, we should mean something with time in the denominator. Now, I should warn you, even epidemiologists don't always use these terms correctly. You'll see prevalence rate even though prevalence is technically a proportion. You'll see mortality rate when it's sometimes a proportion. Don't let sloppy terminology confuse your understanding. Know what the calculation actually is, regardless of what it's called. Prevalence measures the burden of disease, how much disease exists in a population at a given time. The formula is simple: prevalence equals the number of existing cases divided by the population at risk, at a specific time. If 880 out of 10,000 adults have diabetes, the prevalence is 8.8%. Point prevalence measures disease at a single point in time, a snapshot. Period prevalence measures disease over a time interval, say, annual prevalence of influenza. Here's a crucial concept: prevalence is affected by both incidence and duration. High incidence increases prevalence. More new cases means more total cases. Long duration also increases prevalence, people stay sick longer, accumulating cases. A cure or an effective treatment that shortens disease duration actually reduces prevalence. This has counterintuitive implications. Better HIV treatment that keeps patients alive longer increases HIV prevalence, even if incidence is declining. That's a good thing, but you need to understand why prevalence is rising. For healthcare managers, prevalence is essential for planning. How many dialysis chairs do you need? Depends on prevalence of end-stage kidney disease. How many diabetes educators? Depends on diabetes prevalence. Prevalence tells you the burden you're managing today. Incidence measures new cases, the risk of developing disease. This is fundamentally different from prevalence. Cumulative incidence, also called incidence proportion or risk, is the number of new cases divided by the population at risk at the start of the period. If 100 people out of 10,000 develop diabetes over 1 year, the annual cumulative incidence is 1% or 10 per 1,000. Incidence rate, also called incidence density, uses person time in the denominator. This accounts for people who enter and leave the population during the observation period. If you observe 10,000 people for varying amounts of time totaling 9,500 person-years, and 95 develop disease, the incidence rate is 10 per 1,000 person-years. Why does person time matter? Consider a study where some people are followed for 5 years and others drop out after 6 months. Cumulative incidence doesn't handle this well. Person time gives credit for however long each person was observed. For healthcare managers, incidence matters for prevention. If a smoking cessation program reduces lung cancer incidence from 5 per 1,000 person-years to 3 per 1,000 person-years, you can calculate lives saved. Prevalence wouldn't show this effect for years, until existing cases die or are cured. Let me illustrate these concepts with Canadian diabetes data, something directly relevant to healthcare management. Diabetes prevalence in Canadian adults has increased dramatically, from about 5.5% in 2000 to 8.8% in 2020. That's roughly 3 million Canadians living with diagnosed diabetes. But here's what's interesting, diabetes incidence has been relatively stable, around 6 per 1,000 person-years. New cases aren't increasing dramatically. So why is prevalence rising if incidence isn't? 2 reasons. First, people with diabetes are living longer thanks to better management. Longer duration increases prevalence even with stable incidence. Second, the population is aging, and diabetes prevalence increases with age. The denominator is shifting toward higher-risk age groups. For healthcare managers, this has major implications. You need more endocrinologists, more diabetes educators, more dialysis capacity, not because more people are getting diabetes, but because more people are living with it. This example shows why you need both measures. If you only looked at prevalence, you might conclude diabetes prevention is failing. If you only looked at incidence, you'd miss the growing service burden. Both pieces of information are needed. Mortality measures tell us about death, the ultimate health outcome. Crude mortality rate is total deaths divided by population. Canada's crude mortality rate is about 8 per 1,000 per year, roughly 300,000 deaths annually in a population of 38 million. Cause-specific mortality rate focuses on deaths from a particular cause. Cancer mortality rate is cancer deaths divided by population. This tells you the risk of dying from cancer in that population. Case fatality rate, or CFR, is different, it's deaths divided by cases of disease. This measures the severity or deadliness of a disease among those who have it. Ebola has a CFR of 50% or higher. Seasonal influenza CFR is around 0.1%. COVID-19 CFR varies by age and healthcare access but is roughly 1 to 2%. Age-standardized mortality rates adjust for population age structure. Japan has a higher crude mortality rate than Guatemala because Japan's population is much older. Age standardization allows fair comparison by applying the same age structure to both populations. For healthcare managers, mortality data drives priority setting. Which conditions are killing people in your catchment area? How does your mortality compare to provincial or national benchmarks? Are there disparities in mortality by neighborhood or population group? Let me spend a moment on person time calculation because it's essential for incidence rates. Person time is the sum of time each individual contributes to the observation period. If you follow one person for 5 years, that's 5 person-years. If you follow 5 people for 1 year each, that's also 5 person-years. Each person's contribution stops when they develop the disease of interest, die, drop out of the study, or reach the end of the observation period. Let's work through an example. You're studying heart attacks in a workplace wellness program. Person A is followed for 2 years then has a heart attack. Person B is followed for 3 years then moves away. Person C is followed for 5 years with no event. Person D is followed for 10 years then the study ends. Total person time, 2 plus 3 plus 5 plus 10 is equal to 20 person years. If persons A and D had heart attacks, that's 2 cases in 20 person years, or 100 per 1,000 person years. This approach fairly handles the reality that people enter studies at different times, stay for different durations, and have different outcomes. It's more flexible than cumulative incidence, which requires everyone to be followed for the same period. You'll encounter person time in research literature constantly. Understanding the calculation helps you interpret results correctly. During outbreaks, we use specialized measures. Attack rate and secondary attack rate are essential concepts. Attack rate is the proportion of exposed people who develop disease. Strictly speaking, it's a cumulative incidence for a specific exposure during an outbreak. If a church potluck has 200 attendees and 50 develop gastroenteritis, the attack rate is 25%. We use attack rate when studying acute, time-limited events where the exposure is defined and the time period is short. It's not appropriate for chronic diseases with long latency. Secondary attack rate measures transmission within households or close contacts. If 10 index cases each have 4 household members, that's 40 contacts. If 12 contacts become ill, the secondary attack rate is 30%. This measures person-to-person spread after initial introduction. For healthcare managers, these measures are critical during healthcare-associated outbreaks. A norovirus outbreak in your long-term care facility, what's the attack rate among residents? Among staff? What's the secondary attack rate in affected units? These numbers guide your response. During COVID-19, secondary attack rate data influenced infection control policies. Household SAR for COVID was roughly 10 to 20% for the original strain, higher for Delta and Omicron variants. Raw numbers and rates require context to be meaningful. Let me give you some interpretive guidance. Always consider the denominator. A hospital with 20 surgical site infections sounds bad, but what's the denominator? If they did 20,000 surgeries, that's 0.1%, excellent. If they did 200 surgeries, that's 10%, alarming. Rates are only interpretable with denominator context. Crude rates are appropriate for describing burden in your actual population. Adjusted rates are necessary for fair comparison between populations with different structures. Compare your age-standardized mortality rate to the provincial benchmark, not your crude rate. Confidence intervals tell you about precision. A rate of 5% with 95% CI 4.8 to 5.2% is precisely estimated. A rate of 5% with 95% CI 1 to 15% has huge uncertainty, probably a small sample. Wide confidence intervals should temper your conclusions. Single values are less informative than trends. Is your readmission rate increasing, decreasing, or stable? One quarter's data doesn't tell you much. Track rates over time to identify meaningful patterns. Finally, compare to appropriate benchmarks. Is 3% hospital mortality good? Depends on your case mix. Compare to similar institutions or use risk-adjusted benchmarks that account for patient characteristics. Let's summarize this week's content on disease frequency measures. Prevalence measures disease burden, how many people have the condition at a point in time. Use it for capacity planning and resource allocation. Remember that prevalence is affected by both incidence and duration. Incidence measures disease risk, how many new cases occur over time. Use it for evaluating prevention programs and understanding disease etiology. Incidence rate using person time is more flexible than cumulative incidence. Mortality measures include crude rates, cause-specific rates, and case fatality rates. Each answers a different question: risk of death in the population, risk of death from a specific cause, and severity of disease among those affected. Person time calculation allows incidence rates to handle variable follow-up periods fairly. Understand how it's calculated to interpret rates correctly. Context is essential for interpretation. Consider denominators, use appropriate adjustments for comparison, attend to confidence intervals, track trends, and compare to relevant benchmarks. Next week, we'll build on these measures to examine measures of association, how we quantify relationships between exposures and outcomes. You'll learn relative risk, odds ratios, and attributable risk. For your assignment, calculate the prevalence and incidence of a condition relevant to your workplace using available data. Be prepared to discuss your calculations and interpretations in class. See you next week.